Yeah.
So let me, as Scott mentioned, I am a founding board member of NBPAS. But I think it's important in background. I am one of those grandfathered folks for internal medicine and cardiovascular medicine, but was not grandfathered for interventional cardiology because that board didn't exist until 1999. I took the initial exam in 2009 when it came up for recertification. I said, this is nuts. That after 40 years of practicing interventional cardiology, I don't need to be recertified to prove to me or my patients or my colleagues that I'm a competent interventionalist. And so when this whole thing came up now in 2014, Paul Tierstein previously mentioned, there's a listserv that a lot of us interventional cardiologists participate in. Paul basically posted something that said, enough is enough. And I was one of the first people to say, you gotta be kidding. It's about time we stepped up to do something about this, which is why Paul asked me to participate. And the first thing that happened from that activity was a petition that basically said, MOC's gotta stop. And in a very short period of time, just by word of mouth, just by social media, more than 25,000 physicians agreed that this was enough, that we had had enough, we couldn't do this anymore, this was painful, onerous, and irrelevant to the care of our patients. Interestingly, for those who may not be aware, British physicians, particularly those in the National Health Service, can in fact strike and have a collective bargaining activity. And this is an editorial from the BMJ shortly after NBPAS was formed. It basically said we finally got there, and physicians in the United States have finally raised their hands and said enough is enough. So that basically is the background to the formation of NBPAS. And it started with the change in the ABIM requirements for continued certification relating to MOC. Although it sounds reasonable, as we've all heard here this morning, it really doesn't make any difference as to the care of our patients. Physicians consider this time-wasting, costly, busy work not relevant to patient care, and the CME actually, if done correctly and in a meaningful way, actually does provide the kind of ongoing educational activity that I think all of us would willingly participate in. Medicine changes very quickly. There's lots of new science that comes out. I think we all have our patients' best interest at heart and want to be as knowledgeable as possible as we can be for the areas of healthcare that we provide. And we've talked a lot already this morning about the economics. So interestingly, and I have to admit, I still pay my ACC dues, although I challenge myself every December when I get that bill as to whether I should still do it or not. But a survey from the American College of Cardiology basically points out that 90% of our members oppose the ABIM MOC requirements. Despite that, the ACC is a participant in providing MOC activities and obviously making money out of that activity. As was described, we too support the initial certification. I'm a program director. I should mention I can't be an interventional cardiology program director because I am not ABIM recertified in interventional cardiology, which is totally nuts. But I am our general cardiology program director. And I do think there is a value, given the variations in training program and experience and backgrounds of the people we train, that there be an initial bar, much like the lawyers have to pass a bar exam, that represents the initial knowledge base at the time of physicians coming out of training before going into clinical practice. And I think there is value to that, but that's kind of where it ends. We don't believe that follow-up examinations are necessary, and we do think that CME is an appropriate mechanism for verifying that ongoing education and currency is maintained. NBPAS is a not-for-profit. We are a 501c3. The fees are very low. It's basically, it's a 2-year certification. It's $165 for the 2 years, and that represents every certification, every recertification that you want to do. So if you want to recertify in internal medicine, cardiology, and interventional cardiology, you get it all for one price. Okay? We're not parsing it out to individual certifications. And basically, it's driven by our expenses. We have staff that we do certify that the CME that is being reported is in fact valid CME. And there are random checks because one of the other requirements is that people have to be maintaining clinical privileges in the areas that they're asking for recertification in. So there is sort of a random sample to make sure that people are actually saying that I still have privileges in my hospital. And the physician management is totally unpaid. None of us get any salaries. Paul doesn't get any salary. And he probably invests more time and effort into this than any one of us or all of us combined. So this is a letter, the first letter that Paul got from the ABIM that basically said, gee, we're sorry, we got it wrong, and we're going to do something better. Yeah, okay. That and 50 cents got us a cup of coffee. This is the most recent apology, if you will, or change in this. And one of the things that changed here is the change from the single 8-year exam to, okay, if you do okay on these exams every 2 years, we'll let you not take that 10-year exam. So, should we celebrate? Is this a wonderful thing? Well, maybe not, okay? So what the current recommendation, the current policy is, replaces one large waste of time with 10 smaller wastes of time. And as we've said multiple times this morning, there's no evidence that MOC improves patient care or quality of care. The cost is still $200 to $300 a year. So it's still $2,000 or $3,000 over 10 years. So all it is, you know, it's a payment plan. It's not really a change in the overall cost of what this entails. And as again mentioned, it preserves the ABIM revenues. I think some of my slides don't show up. So, in just over a year of operation, and we've now been operating longer than that, we have about 4,000 physicians who have recertified in one thing or another through NBPAS. Also this year, and I don't know if there's any osteopathic physicians in the audience, but there's now, I see one, good. You know, or actually there's a couple. There's now a parallel board for osteopathic physicians, for those who were trained not through the ABIM system, but through the osteopathic system, who can now do the same thing with NBPAS. So please let people know that, and that's really just launching in the last probably 4 or 5 months. But clearly another opportunity to change the direction of both the boards of certification. Also point out that a growing number of hospitals have changed their bylaws to allow NBPAS as an alternative. And who are those? So here's some of them, and they span the country. from Florida to Washington, or Florida to Alaska actually, and across the board. Now I will point out a lot of these are smaller hospitals. Not that that's a bad thing, but you know, it takes a lot of smaller hospitals to have an impact as opposed to some of the larger, more visible institutions that we're trying to engage in this process. These are a few more. And some of them have changed their bylaws that allow ABMS or AOA certification and now includes NBPAS as an option. Some have been a little vaguer in their language, but we don't necessarily feel like NBPAS needs to be specifically mentioned in these bylaws or in some of the state laws and regulations that are coming down the pipe, but just that there needs to be an alternative. So for example, how many people in the audience realize there's actually an alternative to the Joint Commission for your hospital certification? Not a few, more than I actually expected. So just like there's an alternative to Joint Commission, we see NBPAS at this stage as the alternative to the ABMS. We talked about other organizations. There's lots of state medical boards. There are medical associations. There are physician societies such as the American Association of Clinical Endocrinologists, the California Neurologic Society, the American College of Anesthesiology, and others. The ACP has come out, this is as of last fall, position that a board, that MOC should not be an absolute prerequisite for licensure, hospital credentialing, or importantly, health plan participation, because I'll come to that in a second, but that's becoming a bigger issue. This is, I think here at this meeting, there are, this was last year's House of Delegates from the Washington State Medical Association. This is another resolution to the AMA and others. Wes already talked about the Oklahoma, and really it's clear, the language here is critically important, that MOC as a condition of licensure, reimbursement, employment, or admitting privileges should not be a criteria, okay? Having this as part of the state laws is a game changer, I think, for a lot of us. So what can you do? So support from private payers is clearly one of the big challenges. The response that we get when we've tried to approach payers is, how can that help? How can doing anything about a MOC help us? And it's a hard argument to make, except that it shouldn't be the default that you be required to be board certified, currently board certified, in order to be part of any particular payer panel. But getting access to the payers and getting them to understand what this really means has been one of the challenge. So we think that the ways to overcome this is laws like the state of Oklahoma. Everybody in this room, if you have a connection to a local payer group, to have this conversation with them and to make sure they understand why this is an important differentiator and important activity to change their policies. In the state of California, for example, they can't advertise that they're board certified unless they're ABMS board certified. Okay, so I couldn't advertise that I'm board certified interventional cardiologist because I'm not ABMS board certified in interventional cardiology. I was, but I'm not currently. So how do we get other states to adopt a law? You need to get certified. There's by NBPAS. There is strength in numbers. The more people we get that are signing up, and again, it's not about the money for us, for NBPAS, it's about the message. The more people who sign up, the louder voice we have, and the more impact we can have in changing MOC. Use the resources available on the website. There are PowerPoints, many of the slides that I used are on the website. There are letters that you can send to your medical executive committee, to local legislators. Spread the word, talk about this, make sure that the people in your own hospitals understand how important MOC reform or elimination really is. Lobby your MEC to accept NBPAS or alternative recertification modes as valid as part of your credentialing and criteria, and make sure that they understand why that's important. It's particularly important right now, as I mentioned, for academic organizations in terms of us being able to provide educational activities to our trainees and to hospital systems, and because they tend to be larger institutions that will get more visibility for the physician-driven changes that are necessary in MOC. And talk to your payers. It's up to us. Change is inevitable. We should be those agents of change as far as MOC is concerned.